If everybody wants to get settled in, get a comfortable spot, we're going to get started. Couple housekeeping things. My name is Julie, and I am a part of the planning committee at Komen. If you have any questions or concerns around anything with the conference, feel free to let me know. There are bathrooms right outside the door here. There's also some water and glasses out there if you need something. This presentation is simulcast. So when it comes to the question and answer period, which we'll have at the end, there's a good 15-minute period at least, we're going to ask that you write your questions on a note card. We'll be coming up and down the aisle with note cards. That way we can read them out and make sure that the simulcast sites, and there are a few of them, can hear the questions and answers. Any questions about any of that? We'll walk up and down. So the presentation's just about an hour with a time period for questions. So today, this session is New Methods in Reconstruction. Dr. Hetal Fichadia will be doing the presentation. She is currently with the Oregon Clinic, practicing, I think, mostly on the west side, but I might be wrong about that. Dr. Fichadia is a dual board certified in plastic and reconstructive surgery. She did her general surgery training at St. Elizabeth's, which is an affiliate of Tufts in Boston. She has presented her research and work from her time in Boston and in Portland at national conferences, surgical conferences. She has an international upbringing, which has really left her sensitive to some of the disparities in access around the world, and has done mission trips to developing countries to help with those global health initiatives. She is a great member of the team that we are working with at Providence, and her interest is high interest in breast reconstruction, implants, new methods, especially the PrePectoral implants, and fat grafting. And so I would like you all to welcome Dr. Fichadia.
Can you hear me? If you can't hear me during the talk, please let me know, and we'll adjust. It's a great pleasure and honor to be here this morning. I'd like to thank Susan Komen, Julie, for inviting me over to talk about new methods in breast reconstruction. So I'm a plastic and reconstructive surgeon. I practice the broad spectrum of plastic surgery, including breast reconstruction. And breast reconstruction by far is one of the areas that has seen the most advance in the past 10 years or so. And so I'm very thrilled to talk about some of those advances and what's new and what we can look forward to. I have no financial disclosures. I will be talking about some surgical technology and products, but I have no financial affiliations with any of those. I have used photographs of my own personal patients, which are published or used with permission, as well as pictures of other surgeons' patients, which are also published and credited appropriately with permission, and some photographs from journal articles. So my goal today is to go over the story of breast reconstruction, how we got here, where we've been, what are some of the recent advances to getting better results, and then what some of the future directions hold for the field of breast reconstruction. When mastectomy or breast removal surgery was introduced in the late 19th century, the goal was to be as radical as possible. So surgeons believed that the more tissue you took out, the better your outcomes would be from a cancer standpoint. So the concept of radical mastectomy was proposed, and that involved removal of majority of the skin, breast tissue, the two muscles that are underneath the breast tissue, and the resection ended up being down to the chest wall and the ribs. At that time, reconstruction was not in anyone's mind. Reconstruction was in fact frowned upon. They advised against reconstruction for fear of violating local control of disease. And without a good skin and soft tissue envelope to cover any reconstruction, it was doomed to failure anyway. And this thought process persisted into the late, for a better part of 20th century. It wasn't until the 1960s that we entertained the thought of maybe not being so radical. And it was very common for women who had a mastectomy for breast cancer to have a disfiguring deformity such as this that affected their quality of lives and had a lot of comorbidities with shoulder issues, pain, etc. As you can see, though, with lack of any kind of skin or soft tissue support, it would be hard to attempt any reconstruction in somebody like this. And so it took a long time for the surgical community to question themselves about, do we need to be this radical? Do we need to remove all the muscle? Do we need to take off the skin as much as we take off? And that's when they realized that we could be less radical. We could save some of the skin and save the muscle and yet have similar oncologic results and not compromising the patient's survival or disease-free interval. And so it was around this time that silicone breast implants were introduced for cosmetic purposes. And it wasn't long before the two ideas came together and where the silicone implants started being used for breast reconstruction. So initially, because this was such a radical concept, we started doing it in a delayed manner. Everybody wanted to be sure that patients recovered from their mastectomy surgery and they were disease-free before offering reconstruction. And so it was done in a delayed manner once the mastectomy flaps, the skin, and the soft tissue over the chest wall had healed. And because the skin had been so contracted, the reconstructions were two-stage reconstruction, where the first stage would be placement of a flat spacer or a tissue expander, which would then be inflated gradually with saline. And once they got to the desired size, then swap out for final silicone implants to make it match the other side as much as possible. And this remains still, the two-stage tissue expander to implant-based technique still remains the most frequently utilized technique for implant-based reconstruction in the United States. But that is also changing very slowly, and we'll talk about more of that later. In the 1970s, first reports of immediate reconstruction started coming in, where plastic surgeons would work at the same time after the breast cancer surgeons were done to place an implant and recreate the breast mound. Other than using silicone breast implants or saline breast implants, we also had better understanding of the blood supply and the circulatory patterns of the muscle and the overlying skin around that time. And so we started using creative ways to reconstruct the breast mound using your own body tissue, also known as autologous reconstruction. And this involved sacrificing the muscle of the abdomen, the six-pack muscle, if you will, and the muscle of the back. And with the advent of microsurgery, which is really technically demanding and fine surgery, we started saving more and more muscle. So most of our autologous reconstruction at present involves dissecting the skin and the soft tissues and the fatty tissue away from the muscle and taking just that, saving most of the muscle as much as you can to do free flaps, which is then connecting the donor tissue to the recipient tissue with microvascular reconstruction. Another advance around it's not an advance but more a socio-political thing which helped the cause of breast reconstruction was that breast cancer advocacy helped make cancer reconstruction be a covered benefit. And this didn't happen until the late 90s. So it was in 1999 that Women's Healthcare Rights Act was enacted, and that made it mandatory for most insurances to cover breast reconstruction, which also improved access for patients with breast cancer surgery. So when I talk about advances in breast reconstruction, it's easy to see that breast reconstruction is closely related to advances around mastectomy, advances around the kind of the coverage that our cancer surgeons leave us that enables us to do a great job at reconstruction. And then there have been advances both in implant-based reconstruction as well as in reconstruction using your own tissue. So we'll talk a little bit about both implant-based and autologous reconstruction. And then just a final note about how decision-making process has evolved during the past 10 years. As I mentioned, we're only as good as the mastectomy flaps that we're left with. And so as mastectomy techniques became less and less invasive, we had better and better tissue to work with to give a good breast reconstructive result. We went from a radical mastectomy, removing all the skin and muscle, to modified radical mastectomy, which saved the skin, saved the muscle and some of the skin, to skin-sparing mastectomy, which is just taking off enough skin to allow for a nice closure, but leaving behind most of the skin. And what this did was give us that coverage that was needed to do a good job at reconstruction. But the great advance in the last few years has been a nipple-sparing mastectomy, and we'll talk about that in just a moment. This is somebody who had a skin-sparing mastectomy, really nice results. Skin-sparing mastectomy, you still can see a visible scar, but she also needs a nipple and areolar complex reconstruction, which can be done after the final implant exchange has been done. The implants have settled, and finally tattooing is done to add some pigment to the nipple and areola, making it look as natural as possible. However, nipple-sparing mastectomy has been another step further in evolution of mastectomy approaches. So we asked ourselves, if we could save most of the skin, why couldn't we save nipple and areola in patients where the cancer was far from nipple and areola? Could we save it for patients where it was a little bit closer to the nipple, but yet not under the nipple? So whereas indications were initially limited to some patients who had really small tumors very far away from the nipple, we're doing more and more studies. We're finding out that even slightly larger tumors, not really large, not directly behind the nipple, those patients can be candidates for nipple-sparing mastectomy. And studies have shown that saving the nipple and the areola results in better psychological and sexual well-being for patients who battle breast cancer and have reconstruction. And so there are many approaches to doing a nipple-sparing mastectomy. Approaches around the nipple where you can have an incision that goes outside the nipple on the outer chest wall area, incision that goes vertically down the nipple, incision that curves around the nipple and areola and then goes outside. But my favorite and by far the most cosmetically helpful incision is the incision that is in the breast fold. And this incision is better from a standpoint of nipple perfusion or circulation. And more importantly, it's great from an aesthetic standpoint because it hides in the nipple, in the breast fold, and it's very easy to camouflage. So we're able to give really nice results with no visible obvious signs of mastectomy for somebody who's looking at it from the front. So this is an example of a patient who had a two-stage reconstruction with tissue expander and implant placement. There is a scar from a prior biopsy on her left upper breast, and her nipple areolar complex incision goes from around the nipple and sideways. This incision has a slight tendency to pull the nipple and areola outwards, but most of the times heals well without any problems. But even between this and this is a patient who had a bilateral mastectomy for malignant rhabdomyosarcoma of her breast. And This is a personal patient, and my breast cancer, I'm very fortunate to work with some cancer surgeons who are willing to do that extra work to place that incision in the fold and make me look good. It is technically more demanding. It's technically more challenging because you are working on getting that breast tissue out from the innermost corner from an incision that's so far. So I joke with them that I owe them a massage therapy session after all of these nipple-sparing mastectomies that they do from that fold incision. As you can see, this patient, you would be hard-pressed to tell that it's a mastectomy reconstruction, and be easy to admit that this could be a cosmetic breast patient. Not everyone's a candidate for this. If the nipples are located low, or if there's a lot of extra breast skin, the point of nipple-sparing mastectomy is lost in that because we try not to leave the nipples in a less than aesthetic position. And so I would advise against a nipple-sparing mastectomy. But for the right patient, this is a fantastic operation. This is another one of my patients where, again, a breast fold incision. It's much longer than a traditional cosmetic breast augmentation incision because you have to do a mastectomy through that. But after healing, it hides really well and gives a great result. The second advance that a nipple-sparing mastectomy and the fact that yes. Thank you for pointing that out. Is this good? Okay. So the other thing that we started asking ourselves as our surgeons left behind more skin and the nipple was that did we really need to do this two-stage reconstruction? When two-stage reconstruction was introduced, where we would put in a flat tissue expander or a spacer, followed by expansion, and then switching over to the final implant when the skin was stretched enough, that was when we used to do more radical procedures, when we didn't have as much skin to work with. And so the rise of nipple-sparing mastectomy and skin-sparing mastectomy made us ask ourselves if we could do it all in one. This was pushing the envelope because plastic surgeons and surgeons in general are very scared of the mastectomy skin flap and its delicate circulation. After a mastectomy or removal of breast tissue, the skin over it is relying only on the circulation from the surrounding skin. And so anything that adds stress to that skin or pressure to that skin can result in flap necrosis, which can be a devastating outcome for somebody where there is an implant or a free flap underneath and the covering part of the skin dies and leaves an open wound. That means there's reconstructive failure, implant needs to come out, and we got to start all over again. So this was when we were pushing the envelope about could we put in an implant and yet not stretch the skin enough? But because our surgeons are leaving so much skin, healthy skin and nipple for us, we are doing some direct implant reconstruction, which obviates the need for that second stage, obviates the need for doing tissue expansions, weekly visits to the doctor, trying to get to the right size, and then switching over, which can be a tremendous benefit for patients. This is another, and as you can see, this is somebody who had a nipple-sparing mastectomy with a vertical incision that goes down, again, with really nice, decent results. This is someone who had a direct implant reconstruction. The one thing that I tell my patients, and that applies to direct implant reconstruction, is that you're not able to go from a small breast to a large breast after reconstruction if we are thinking of doing it in a single stage, because you don't want to stretch the skin too much. You don't want to put additional pressure on the skin. If a patient is okay with being about the same size or maybe being a little bit smaller or a tiny bit larger, that's a great candidate for a direct implant reconstruction. But for everybody else, a standard two-stage reconstruction is still the safest way to go. Somebody who had a direct implant reconstruction after a nipple-sparing mastectomy through a breast fold incision with really nice results. The second advance that has helped me and made my life easier, as the life of all plastic surgeons around the country, has been the ability to identify during surgery whether the skin will be hardy enough to take the stress of the breast implant. And earlier, we used to rely on our clinical and visual judgment, which is not very accurate when there's a lot of swelling from the surgery, bleeding. It's hard to define exactly which part of the skin won't do so well versus which part of the skin will heal really nicely. And so the introduction of InGeography, which we can do real time in the operating room when the patients are asleep, has enabled us to be more accurate in predicting these things. I have no financial interest with this company or the machine, but this SPY InGeography is a technique where you inject indocyanine green when the patients are asleep in the OR and see whether this reaches the breast flap skin. And you can tell where there are areas of poor perfusion and trim those areas so that you're not left with having the problem of having an implant with dead skin on top of it. It has multiple applications all over the body, but this is something that you can do in the OR when the patient's asleep. And the periphery, the white area that lights up, is the area that has good circulation, and the central area, which is the dark area, is the area that needed to be trimmed and would not have made it had we done reconstruction. SPY has allowed me, this is another example of a picture where you can get color images with that, but someone who had a free flap and the mastectomy skin here didn't look so great, and that's the part that ended up having some loss of the superficial skin. While not 100% accurate, it has allowed me to make decisions during surgery where I can say, you know, maybe we shouldn't do a direct implant reconstruction today. Maybe this would be a better candidate for doing a two-stage reconstruction. So I can have a discussion with my patients that I know you want a direct implant reconstruction, and I will do my best to do that. But if the circulation doesn't look great, our only other option would be to have an implant but have dead skin on top of it, which is not good for anybody. And so at that point, we decide whether the skin would be better off by putting a flat spacer, or whether in more extreme cases where it looks, where the circulation looks really bad, whether we abandon the attempt at immediate reconstruction and come back later when the skin is all healed up to give a better result. Because any time a reconstruction gives the best result when it's done the first time. If we're going back after a failed reconstruction, you're already starting from the back foot, and that's never helpful. It has also helped us with postoperative complications. So patients who've had SPY use of the InGeography with trimming of the skin as needed versus patients where it wasn't used was a significant difference in the complication rate afterwards. And so I don't think we need to do that for everybody. Most of the times we could tell by clinical judgment, but for the times where I'm not sure, I think this has been a great addition to our operating rooms, and I'm fortunate to say that it's available in the hospitals where I work at. There have been so many, moving on to implant-based reconstruction, so many advances around implant-based reconstruction that, again, has allowed us to offer better reconstructive options to our patients. The breast implants as devices have have improved and we have better choices now. The use of acellular dermal matrix, which is a surgical scaffold, we'll talk about it in just a moment. As I mentioned, direct to implant reconstruction, a little bit about it, we'll go over that in a little more detail again. The use of fat grafting, again, very exciting part of the current arsenal in the breast reconstructive surgeon's armamentarium, and finally, PrePectoral reconstruction. So it used to be that breast implants would come, they're saline or silicone, with different sizes based on their volume, and those were the choices we had. The implant companies have come up with so many new advances where we have two options in terms of the shape of the implants. There's the round implant and there's a shaped implant. The shaped implant is supposed to be like a teardrop shape that maintains its shape. And for patients who have unilateral reconstruction just on one side, it can be very hard to match the natural breast shape and droop, which would be hard with an implant that's round and sort of, giving that upper pole fullness without having the nice and natural droop of the breast. So for us to be able to use a shaped implant to mimic the natural breast has helped us promise our patients that it would be closer than if I were to use a round implant. The next big thing that is device related is just the improvement in the devices. So the older generation silicone implants that I sometimes remove have silicone gel that is watery, that's fluid, that bleeds and flows if it ruptures. And the company started making more cross-linked silicone with better properties, so that at present, some of the cohesive gel implants, which we use extensively in reconstruction, can be cut, and yet the silicone doesn't flow. It's solid. So even if there is a small area where there is a potential leak in the future, you won't have a frank leak of silicone. And these are generation 5 implants with cohesive gel. Now these also come in different patterns of cohesivity. So depending on how much you vary the fill ratio of an implant, you can have implants that are more firm. They're firmer than a normal breast would feel, but they're more resistant to rippling or wrinkling, which is a concern in reconstruction after mastectomy, not as much after a cosmetic breast augmentation. So as you increase in the level of cohesivity from level 1, 2, 3, as you can see, when you put them upright, the implants have less and less tendency to ripple or wrinkle. But it comes with a trade-off, and the trade-off is that the implants that are less likely to ripple do feel more firm than regular breast tissue. So this allows me to have discussions with my patients on their priorities. With a single implant company, I have a choice of about 600 implants that I can pick from to find something that fits my patient's anatomy as well as I can. And then the shaped implants have the highest cohesivity. They are also textured implants, and there have been some other concerns with textured implants that are beyond the purview of our talk today, so I'm not going into that. The next advance in our implant-based reconstruction has been the availability of surgical scaffolds. So these have been in use for about 12 to 15 years. They're becoming more easily available, easily used. Basically, what they are dermal membranes that can be from donated human dermis or pig dermis. The cellular elements are removed, and it's basically surgical grade leather that you can use to support your implants within your reconstruction. And this has been a great advance in that it has versatile applicability. For traditional reconstruction under the muscle, we use it to support the lower pole where the muscle, pectoralis muscle is in the upper 2/3 of the chest. When we put the implant underneath it, we use dermal matrix or the surgical scaffolds to hold the definition of the lower pole, which helps to define the area of reconstruction as a breast, because that lower pole definition gives it a nice breast-like shape. For the right patient, it enables a direct implant reconstruction, whereas the tissue expanders were used to work with smaller space and then expand it gradually. With us being able to use surgical scaffolds, we can place implants that are the final size right away, because now we have the ability to make space for those implants. Because it acts like an internal bra, it takes the stress away from the mastectomy skin. So it bears the weight of the breast implant and allows the mastectomy skin to just drape over it, and therefore helping with not putting undue stretch or pressure on the skin. For patients who have a tissue expander-based reconstruction, when we use a surgical scaffold, we are able to put in more volume of saline initially at the time of surgery, and that reduces their need for postoperative visits, postoperative fills, and that's also beneficial. Like any new technology, this is not without its problems. Anytime you use a foreign substance, there is a chance that you can have collection of fluid. It's called a seroma. These can sometimes stretch over time, and they do add cost to the surgery. The next exciting thing that I use extensively, and as do a lot of breast reconstructive surgeons, is fat grafting. So this used to be a question that would be asked jokingly. Can you take fat from somewhere and put it somewhere else? For cosmetic purposes. And we do use fat grafting for cosmetic purposes for breast augmentation using your own tissue versus an implant. But it has found a really a nice application in breast reconstruction because fat comes with stem cells and it has regenerative properties. And so what we do, technically what we do is use liposuction to harvest fat. To harvest fat from other parts of the body, process the fat, and then inject it in small quantities to where we need it. In breast reconstruction, this means we use it to smoothen out the contour issues that can happen after mastectomy, little divots that can be created after a mastectomy. For implants, if we've used implants along the edge of the implants, if there's a shelf along the edge of the implant, that the transition from the chest wall to the breast implants, fat has an excellent application for that. One very special thing that fat can do is to help with radiation damage to the skin. So radiation, as you know, is good for cancer, but can damage a lot of the surrounding tissues, skin being one of them. And what it does is it hampers the circulation, the vascularity of the skin, makes it really stiff and thin. And fat grafting reverses some of those changes. This is somebody who had a failed implant-based reconstruction after radiation and wanted to attempt a second implant-based reconstruction, which is traditionally, in the face of radiation, an implant-based reconstruction has lower rates of success than an autologous reconstruction. But using fat grafting to allow the skin to be pliable and healthy allowed them to do another successful implant-based reconstruction. That adds a lot of value to our existing reconstructive options and is quite versatile. The earlier concerns in the earlier part of the 20th century, like in the early 2000s, were whether the stem cells that came with fat would promote cancer formation, new cancer formation. So people were concerned about whether it would be safe to inject fat with some stem cells that came with it into an area that already had cancer. And so there have been multiple studies where it's been shown that fat grafting is safe in patients who've had breast cancer. It doesn't interfere with the detection of breast cancer for future mammograms, and it has been used to fill lumpectomy defects and so on. The one downside to fat is that about 50 to 60% of it survives, so patients may need more than 1 round of fat grafting because some of it gets absorbed. But the percentage of fat that survives is permanent. So as you can see, there have been incremental advances in these technologies. We have the ability to predict if our tissue will be well perfused. Our surgical scaffolds are getting better and more supportive at supporting our breast implants. We're getting better generation of breast implants which are more resistant to rippling and wrinkling. Nipple-sparing mastectomy is getting more and more common, and fat grafting adds to our surgical armamentarium. And so we asked ourselves, did we really need to use the muscle to cover the implant anymore? When in the very early stages when implants were introduced for breast reconstruction, surgeons tried putting the implants directly underneath the skin and met with some disastrous results because the skin didn't survive over the implants. It was too much stress for the skin. The capsular contracture rate, which is the encapsulation around the implants and thickening and tightening of that capsule, was extremely high. And so that was quickly abandoned. And we found a safe method by covering the implants with muscles. Initially, we covered implants all around with the muscle. So we would raise the pectoralis muscle, serratus muscle on the side of the chest wall, rectus muscle from the abdomen, and do a total submuscular reconstruction. This, as you can imagine, had a lot of morbidity with pain, and malposition of the implants was common because all the muscle forces acting on the implants contributed to moving the implant away from where it was originally intended to be. So then we started doing more submuscular reconstruction with just raising the pectoralis muscle and covering the bottom with that sling of the scaffold that we had using ADM, or acellular dermal matrix. And so that mitigated some of the issues with the pain, but raising the pectoralis muscle off of the chest wall had issues, created issues from in the shoulder function. So most patients do report that the shoulder function returns, but it can take several months for that to happen. And sometimes it doesn't come back to baseline. And again, raising the muscle results in more pain. So because we had access to all this new technology, being able to know that the skin will survive, being able to support our implants better, having fat grafting as an option to add more thickness over the implant, we asked ourselves, why can't we just put the implants in front of the muscle? And so that's when the concept of PrePectoral Reconstruction was born. And it's like it has come full circle, but now with better advances to help us put that implant just under the skin over the muscle. So what PrePectoral Reconstruction aims to do is instead of using the left image, which is sliding the implant underneath the muscle and supporting it with our acellular dermal matrix, we're putting the implant in front of the muscle and then supporting the whole thing with the acellular dermal matrix and then draping the skin over it. And the biggest concern that we had in the beginning was how it would affect the skin. It's all about the skin. I don't know if you noticed a theme in my talk, but how it would affect the viability of the skin. And so we used it in selected patients where the mastectomy flaps seemed like they were thick enough, hardy enough. And how did we make that assessment? We made that assessment by using that intraoperative angiography device. And so what are the advantages of a PrePectoral reconstruction? Our breast tissue sits in front of the muscle. It doesn't sit under the muscle. So you are trying to replace tissue in the natural plane of the breast tissue. It has less pain because you're not lifting the muscle. With any mastectomy and reconstruction, the most painful part is where the muscle is elevated. So patients report much less pain, and the recovery is a little bit quicker. You're not doing anything to affect the range of motion in the shoulder. There are not many restrictions in terms of the shoulder range of motion, other than just taking it easy for the first few weeks. And animation deformity is less, and I'll come back to that in just a couple of minutes again. The other advantage, as I said, is it prevents shoulder dysfunction. I have patients who, against my wishes, have gone back to swimming after 8 weeks. I don't recommend it for anybody, but with PrePectoral reconstruction, the restriction in the shoulder motion is not as obvious as with subpectoral reconstruction. Very early results, and some of these studies have been supported by the companies that make those surgical scaffolds, but very early results show that the rate of capsular contracture and encapsulation of the breast implants are low because the implants are now completely covered with that scaffold, and the muscle is not acting upon the implant. So if you're wondering what animation deformity is, for patients who have implants under the muscle, at rest, the implants are not misplaced. But when you flex the pectoralis muscle, the implants can move out to the side. Now, most patients, it's not a bothersome side effect, unless you're doing something like a naked Hulk. But for some patients, it can be an issue. And the movement of the muscle can be bothersome and cause pain, cause self-consciousness when you're working out, etc. And so this is somebody who had subpectoral placement of muscle. And as you can see, when she animates the muscle, when she contracts the muscle, the implants get displaced on the side. This is a temporary phenomenon. The implants come back to their place when the muscle is relaxed. But that was a bothersome effect to her, and so we switched over from a subpectoral reconstruction to a PrePectoral reconstruction, where we now use the surgical scaffold, swap the plane of the implant to in front of the muscle, and that's her contracting her pectoralis muscle, and the implants are not going anywhere. Again, it may not be bothersome to a lot of patients, but that's another added benefit of this technique. This is a video that shows somebody who's pre-op before switching of plane. So again, at rest, looks like a really nice reconstruction. But when they activate the pectoralis muscle, the implants move out and to the side. And this is her after the plane switch to prepectoral position, which is in front of the muscle. And she is flexing the pectoralis, no animation in the implant. So one other thing that I wanted you to notice that can be an issue with prepectoral reconstruction is that when she is I wanted to go back. When she is flexing the pectoralis muscle, if you notice closely, you'll see some rippling of the implant, and that is a little more likely when you put the implant in front of the muscle. So everything comes with a trade-off. If you're putting the implant in front of the muscle, you don't have that much of a thick coverage in front of the implant, so your chances of having rippling are a little bit higher, but your chances of having animation deformity, pain, are much lower. And some of the rippling issues can be fixed with further rounds of fat grafting, but not always 100% of the time. Again, not everybody is a candidate for this technique. The flaps, it's all about the skin. Flaps that are poorly perfused, that are thin, that we don't think will take the weight of the implant or expander well, are not candidates for this technique. Patients with prior radiation where the skin has contracted and shrunk will not have that kind of expansion that we need with a prepectoral reconstruction. Elevated body mass index, active smoking, poorly controlled diabetes are all recommended as patients where this kind of reconstruction would be contraindicated. And patients who are on the other extreme, where they're extremely skinny, where there are no donor sites for fat injections in the future, maybe not that great of candidates, because this technique relies on future fat grafting, or expects that we may do 1 or 2 rounds of fat grafting for better coverage of those superficial implants. In terms of cancer, with any reconstruction, oncologic outcomes trump everything. So from a cancer standpoint, the concern that is raised is that we are placing implants in front of the muscle. And so what if there's a recurrence, and that recurrence is on the muscle side of the tissue? Would the implants hide it? That's the big question. Now, autologous reconstruction using your own tissue has been done in a prepectoral plane for several years. But when you're thinking about changing techniques where before you were pushing the muscle to the front of the implants, thus allowing for that muscle, any kind of recurrence on the muscle, to be closer to the examiner, to pushing the muscle in the back, the question is, will we miss any cancer recurrences that we shouldn't have if the implants weren't there? And that's why, because this is such a new technique, we don't have studies that show for patients who have prepectoral versus subpectoral reconstruction what the rates of detection are. But at this point, the criteria are, if you have a really large tumor, if your tumor is on the muscle, if you have a positive axilla with positive lymph nodes, or if it's a tumor that has a high rate of recurrence from an oncologic standpoint, or there's chest wall involvement. Those are the patients where we don't recommend that they get a prepectoral reconstruction, because we don't want to mask any future recurrence. What are the risks with this technique? There's a risk that if you're putting things in front of the muscle, you don't have that muscle as a protective layer between the implant and the skin, and therefore you can have necrosis of the overlying skin, which can be a problem. Like I mentioned, rippling can be an issue, which can be resolved with some fat grafting and sometimes may not be able to. Visible implant edges, again, similar concept where the edges of the implant are not hidden by the muscle anymore, and so they can be visible, which can be smoothened by future fat grafting. And finally, with any new technology, we only have short-term outcomes available because it's less than 5 years old. And so we're working actively to gather more data and see if this would be something that would have wider applicability. But in the meantime, this has allowed us to do a nice job at reconstructing. This is somebody who underwent a bilateral nipple-sparing mastectomy and a 2-stage reconstruction in a prepectoral plane in front of the muscle, and had nice results. As you can see, her nipples were in a good position before, and she was a candidate for a nipple-sparing mastectomy, whereas somebody who had more of a nipple ptosis or nipple dropping in low, it won't be cosmetically advisable to save the nipples, and so she had a skin reduction mastectomy and underwent a 2-stage reconstruction in a prepectoral plane in front of the muscle with tissue expanders, followed by implant placement, and then finally nipple areolar complex reconstruction. We're asking ourselves, can we negate tissue expanders again, even for a prepectoral reconstruction? So when you're putting implants under the muscle, you still have some safety layer of the vascularized muscle tissue between the skin and the implant. But when you're putting everything just under the skin, the direct to implant becomes a little more of a risky proposition. So this has limited takers at this point in the plastic surgery world, but there are people who are pushing those boundaries and trying to find patients where they would be good candidates. So this is somebody who underwent bilateral nipple-sparing mastectomy with an inframammary fold incision, and had a direct placement of implants, and with a great result. Another patient with slightly larger implants, bilateral nipple-sparing mastectomy with incisions in the breast fold, which are hidden with a direct implant placement. And this is a personal patient. She, that was her priority, was to do a direct implant single-stage reconstruction. And because her nipples and areola were not optimally positioned, we decided to do a skin-sparing mastectomy. She's only 3 months out. Eventually, after it's all healed, she'll get nipple and areolar complex reconstruction if she desires. So this has been a really nice advance, in my opinion, for our patients who get implant-based reconstruction, because putting the implants in front of the muscle gives that natural breast droop that sometimes was not there with the submuscular reconstruction. The second advance that I've seen with tissue expander placement is patient-controlled expansion. So if any of you've had family or friends with breast cancer and had two-stage reconstruction with tissue expander, you probably remember the visits to the doctor where you have a magnet that finds the magnetic port in the expander, and then installation of saline to inflate the expander. This was sometimes the most anxiety-provoking part of a patient's recovery. Most of the times, the mastectomy flaps are numb, and so patients don't feel the pain, but it's still a hassle, one more thing on your schedule. And so a newer device has been introduced where it's patient-controlled tissue expansion. There is a small cartridge with carbon dioxide in that expander, and patients have a remote control that opens the reservoir and allows that carbon dioxide to release and expansion of the device. You can do this in small increments, as small as 25 milliliters. You can do this every day, and can do it from the comfort of your own home. The studies that were financed by the company show that it causes less pain and allows for a faster expansion to the goal size, shorter recovery time, and it can be done daily instead of one big chunk of expansion, and it's needle-free. But the initial studies also show that it doesn't really change the interval between the first and the second stage. And so it's very costly and not available at this point, or not widely available at this point, because it hasn't been shown to make any clinically significant improvements. Finally, I wanted to just say a couple of words about autologous reconstructive techniques. So D-flap, which is the flap where you save most of the abdominal muscle and take the skin and the fatty tissue from the bottom of the muscle, and microvascularly connected to the chest wall blood vessels, remains the gold standard. But microsurgeons are pushing that to see what more can they do to add value to this reconstruction. And two of the big frontiers that they're trying to cross right now are restoring sensation. So D-flaps or any flap surgery is numb because there are no nerves. And so that's a big area of numbness on the chest wall that sometimes is bothersome. And a reminder of the fact that there was surgery here before. And so they started thinking, what if we took some other components with our blood vessels to connect back? And one concept is NeuroTiesation, which is restoring sensation to the reconstructed breast flap. And what that involves is taking nerves from the lower abdominal tissue and connecting it back to the nerves around the rib cage. And this, in early studies, showed some restoration of sensation. Whether this will be clinically relevant or significant remains to be seen, but that's a pretty exciting idea. And the second one is, which is functionally very helpful, is lymph node transfer. So you probably know someone who had lymphedema. Some breast cancer patients, if they've had axillary radiation or axillary node dissection or even a sentinel node biopsy sometimes, can have issues with lymphatic drainage and lymphedema of the arm, which can be quite troubling. And so surgeons started taking lymph nodes from the groin area and connecting it back to the lymphatic glands in the armpit when they were doing the microvascular reconstruction. This is done by super microsurgery, really, really smaller, even much smaller instruments than microvascular surgery. And that helps with lymphatic drainage in that arm on the same side. And so this is a patient who had a right arm and hand lymphedema, and after right-sided vascularized lymph node transfer had resolution of the lymphedema. So I think this is incredible and would be a great advance. One of my friends at OHSU will start offering this in the near future. I don't think it's really widely available everywhere else. And finally, I just wanted to put in a small blurb about decision making and how decision making has evolved. So we've come long ways from paternalistic decision making, where patients were expected to get recommendations and follow them without questioning. We came into the era of informed medical decision making, where you were given a lot of information and then asked to make decisions on that. And now I find the concept of shared decision making works the best, especially in cases of breast reconstruction. I don't think it's apparent anywhere as much as it's in breast reconstruction, where there are more than one ways to come in at a right answer. And so to the plastic surgery community, it's about meeting a patient, getting their values and preferences in our mind, and then suggesting a few things that may align with those values and preferences. And so it's not a scientific advance, but just an evolution in how we relate to our patients. So that's the end of my talk. I'd like to thank several people. Dr. Julie Hansen, who's the program director at OHSU, who is my mentor, and without who I wouldn't be here. My breast cancer surgeons, Dr. Massimino, Dr. Chelsea Harden, and the Providence Breast Cancer Institute. The breast cancer surgeons do all the hard work to do all those technically challenging nipple-sparing mastectomies, and I can't do this without them. The Providence Breast Center over on the west side for me, Julie, Beth, who's our social worker, excellent support system. And the Oregon Clinic, my office staff, who's really kind and compassionate to my cancer patients. Susan Coleman, of course, for asking me to talk here today. Alan Gabriel, whose pictures I use, some of his patient photos I used, and Bruce Weber, who's my partner, always generous with his knowledge. But most importantly, my patients. They allow me to be with them at some of their most vulnerable times. And I don't take that privilege lightly. I learned so much from them, and they're some of the most resilient folks that I've seen. So thank you so much. I'll take some questions. What I would say for questions is I'm happy to answer general questions about breast reconstruction from the podium. For individual cases, please find me afterwards, and I can talk to you on and on about your individual case. But it would be nice for me to get some more details if we were doing individual cases. So thank you so much. And these are some other ways to get in touch with me. Sorry. I forgot.
I'm going to go ahead and read the questions, and we'll have Dr. Fichadia answer them. I'm going to start with some of the repeat ones. One, can somebody go from a behind the muscle to a prepectoral years later, and what are the contraindications to doing that very delayed?
Yes, yes, you can. So the lady that we saw the video of, you can go from behind the muscle to in front of the muscle in a delayed manner. Basically what we do is remove the implant, release the muscle from the chest wall, stick it back down to the chest wall, and then make a new pocket. In terms of contraindications, any contraindications of a major surgery, so it does take about 2 to 3 hours, so you must be relatively healthy, able to tolerate surgery, and no big issues with like heart issues or lung issues. But yes, that's absolutely possible.
Does the breast feel more like fat and breast tissue than an implant behind the muscle? So is it softer when it's prepectoral?
It depends on the implants we use. So I showed you a spectrum of implants. So for the implants that are in front of the muscle, it's more easy to feel the implants because the muscle's not covering it. So whatever the implant feels like outside of the body, it'll approximate that closer when the implant is in front of the muscle. So if we use a softer implant, they do have some responsive, smooth implants that feel really nice and natural, but they do have a slightly higher tendency of rippling. But if that's a priority, then yes, it can feel more natural compared to behind the muscle because you don't have that muscle to cover it.
Interesting question. With rippling, can you use Botox for muscular ripping? It's not really muscular, though, is it?
It's not really muscular. That's the thing. It's not really muscular, and the thought of coming near my implant with needles scares me. But it's not really muscular. I mean, it's scar tissue that the ripples kind of pull down with it.
What is the difference between the weight of an implant versus natural breast tissue? Is it noticeable?
So the implants weigh more than natural breast tissue for the same size. So if I were to make, or I don't make it, but if I were to recreate the same size breasts, then I would say the implants do weigh a little bit more. And so I would ask for implants that are more in volume in terms of ordering. So they do weigh more, yeah.
Is it noticeable? Do patients?
I haven't had patients complain about it. What I have seen patients bring up is that they are aware that there's something there. And I don't know if, they probably get used to it over time. But usually if a patient, if there's the possibility of using really large implants, like in the 600, 700, 800 cc range, I do go over the fact that they would be heavier and that may not be great for their back and neck.
Is there any evidence that the PrePectoral method does not have good longevity for someone who is very active, running sports, etc.?
That's a fantastic question. So at this point, we don't have enough data. I do think we use surgical scaffolds for holding it up, and those can stretch with time. So if you're using large implants, then maybe. But what I can think about just in a common sense way from a surgical standpoint is to use supportive garments when you're doing high impact exercises in both reconstructions, but in a prepectoral reconstruction for sure, because that doesn't have that muscular support.
This one I think comes from somebody in imaging. For a prepectoral implant, would an MRI be beneficial or an MLO mammogram image?
So again, because I mentioned some of the concerns about imaging, in general, FDA has recommendations about monitoring of silicone implants. So the FDA recommendations are pretty stringent. They start by saying an annual MRI for silent rupture monitoring starting 3 years after and continue it for 2 years after, every 2 years. So if you could use that MRI and add it for, add contrast for diagnosis of recurrence, that's possible. I think that's a question that remains to be answered on what is the best screening way to, I would think an MRI is what I would tell my patients would be an MRI, just because then we can see the chest wall, which may not be obvious with an implant on top of it.
Got 2 questions concerning tram flaps. Are they done often or anymore? And can you recommend performing mammograms on a tram flap?
They are done less and less. Even if they're done in a muscle-sparing way. So traditionally, tram flap used to be where the muscle would stay connected on the top, and you would take an island of skin and then twist it and inset it. That's done much less and less, except in areas where microsurgical reconstruction is not available, which still is a big area in the country. But what we do now is if a deep flap is not a possibility from an anatomic standpoint or what have you, you take a strip of muscle with the deep flap and connect it microvascularly. That would be the next best option other than the deeps. And then for mammography after TAM, I don't think a mammography would be helpful because that tram flap is sitting on, tram flap is done for a mastectomy. And so patients who've had a mastectomy are not recommended to have yearly mammograms. So that wouldn't, if there is a recurrence, it wouldn't be within the tram flap. It would be at the margin of the breast skin in the tram flap or in the chest wall.
How common is or rejection of an implant? How often do you see rejection implant?
So I have not seen an actual allergic reaction to an implant. Silicone is one of the most inert substances on the planet. But you can think of rejection in terms of if patients just don't like the feel of having that heavy mass there, or in subpectoral reconstruction, if it's really, there's some element of muscle tightness that I've sometimes seen patients report. It's not necessarily kind of biological rejection per se, but the fact that it's not compatible with their daily life. In that case, we could either switch the planes or switch to a different way of reconstruction. Although even with the D flap or any flap, you do have some tissue there that wasn't there before. So, but the weight can be an issue for some patients for sure.
Couple questions on the limitations of the prepectoral implants: age, body type, skin condition.
I'm sorry, can I see the question again?
So a couple.
What are the
Does
limitations?
the age of the patient and the age condition of the skin make a difference?
So for patients who are extremely thin, a prepectoral reconstruction would be very hard to do because we are relying on having a nice, healthy thickness of the skin. In terms of body type, so far we've heard, or the traditional recommendations, because it's a new technique, we're trying to be more conservative, is that body mass index of over 40. It's not a great technique because the fatty tissue under the skin doesn't have great circulation, and so you're relying on that to then vascularize the dermal membrane. And so you can have issues where the dermal membrane doesn't take, or it kind of stays free floating, and have recurrent fluid fills and seromas. So those, and radiation again would be hard to do. But there are people who are pushing those boundaries too.
What about capsular contraction? How often is that occurring? What are the limitations with that in reconstruction?
So capsular contraction happens about 10 to 15% of the time. Doesn't always happen right away. It can happen later. For patients who've had radiation, that risk is higher, about 20 to 30%, because of the way radiation affects scar tissue. The newer data for prepectoral reconstruction, what they're saying is that because in a prepectoral reconstruction, the implants are covered almost 360 degrees, if not 270 degrees in the front at least, with that scaffold, the surgical membrane, that's a little more resistant to capsular contracture. And so for the short-term data that we have, there's a slightly lower likelihood of having capsular contracture. But again, it's something that can happen years later, and so we would just have to wait for a few more years till we have more data on that. The second thing about capsular contracture that, it's a phenomenon that still remains a big mystery to plastic surgeons on exactly what causes it. And one of the things that has been proposed is a very low level of bacterial infection. So we've done, there has been like a 14-step plan that's proposed where you change gloves and repeat the skin. Nobody touches the implants other than the surgeon. And a lot of those things to help reduce that low-level bacterial infection to help with the capsular contracture rate. So those are some of the things that we're working on. But yeah.
Are the surgical scaffolds ever used for breast lift without an implant?
Yes. Yes, they are. As are some synthetic meshes. Yeah, they're used to hold tissue pretty much everywhere. Sometimes they're used in hernias and stuff.
I think this question will answer itself. How does the surgical scaffold deal with mammography and does it increase density? But we wouldn't be imaging.
Right, and also the surgical scaffold after a while, it takes about a year to year and a half, in the first few months especially, takes. So it's like it has ingrowth of blood vessels and circulation from the surrounding tissue. So it's basically dermis, which is your skin, with all the cellular elements removed so that they don't your body doesn't reject it. And the longer it stays there, the more likely that it actually will have ingrowth of blood vessels from the surrounding tissues, and it becomes kind of like a part of your body after a while.
How often are you switching patients from the under the muscle to the prepectoral, and what's the major reason they're asking for it?
I haven't had a patient come in to me for switching. I don't think there's a lot of education about the prepectoral technique. But for my friends who've done the switch, mostly it's the animation deformity that's bothersome.
And I think probably last question here, regarding an active metastatic patient wanting a deep flap from a subpectoral, any problems with this type of procedure? For metastatic disease, because a surgery such as a deep flap or any reconstruction has risks and potential of prolonged recovery, and also factors associated with chemotherapy, it needs to be a discussion that is had with the oncologist on what the expected survival is, and whether there is any quality of life benefit to be gained from taking a huge undertaking such as a deep flap for an active metastatic patient. Now, some metastatic patients, have really long prognosis. It's something that I would definitely call the oncologist first before making that offer, for sure. I think that's all we have time for right now. Before we say thank you, I would like to remind anybody who is getting CEUs for imaging, they need to sign in and sign out at the form at the back. Any other types of CEUs, just go to the desk where you signed in originally. If you haven't done it yet, it's by the front entrance. But I would like to give a warm thank you to Dr. Fichadia. It's great information.
You're all great. Thank you.
We have a break period now. You can have time, bathroom, there's the